Biology and biomaterial of implants. Today, we will talk about the implant dentistry from the biological viewpoint and the biomaterial viewpoint. Dr. Brenmark is not a dentist, he is an orthopedist. However, he is being called the father of implant dentistry. The reason is because in 1952, when he did the research on the rabbit leg, he is the first one to find out there is a material which is called titanium can be fixed with the bone. So in the following years, he tried to develop the concept and finally developed the implant systems, and in 1965, he placed the first implant into the patients. So why this founding is so important for the implant dentistry? Because Dr. Brenmark found out there is a fact called osseointegrations really helps us to develop a concept that a foreign body can be fixed with the bone. So osseointegrations means that there will be an apparent direct attachment or connections of osseous tissue to an inert alloplastic material without interfering by the connective tissue. So before we move on, I want you to think about actually the implant placement is very similar like the wound healing. So if we look on the wound healing onto the bone, when the bone has injury, there will be a defect into the bone. So in a few hours to a days, that the blood clot will start to organize together. In a week, then some vascular tissues and mesenchymal cells will try to migrate it to this site and try to overlap the defect. After a few months, then the woven bone and nominal bone will be deposited into this defect and or the socket and finally refill the space. When we talk about the osseointegrations of the implants, so the research found out in few seconds after we place an implant into the bone socket, then the serum protein will come toward to the implant surface and get adhesion. In 3 days, then the mesenchymal cells will also attach and try to proliferate the numbers. In about a week, the bone cell will try to migrate it and started to produce. That means that the bone cells can be deposited directly onto the implant surface. After 2 weeks, the mattress will start to do the calcification, means that the bone is started to mature. Finally, after 3 weeks, the bone remodeling happens. So, if we look on this, you can see the osseointegrations means that the cell can be deposited over the implant surface and then really get a real attachment. That's what we call osseointegrations. So what's the important factors affect the osseointegrations? One is implant material. Second will be implant surface properties. The third one will be the primary stabilities. When we talk about the implant material nowadays, over the market, there are two major options. One is titanium, the second is zirconia. Until now, if we review the market, that we can find out that titanium still dominate the most of the implant dentistry market. The reason is even though the zirconia really has a potential to become alternative dental implant material to titanium dental implants by the research. However, the research also shows that because of the zirconia implant design, they still have more higher failure rate compared to the titanium dental implants. Except the implant material, the implant surface design is also important to affect the osseointegrations. In the first beginning, when the manufacturer and researcher started to develop the implant systems, they tried to follow what the natural teeth have. So we know the natural teeth has a smooth surface. So in the first beginning, the implant surface was developed by the smooth surface. However, the research found out the smooth surface actually is not really helpful for the osseointegration. The rough surface actually is much better than the smooth surface for the osseointegrations. So nowadays, each different brand has their exclusive surface treatments and also claim that they have a higher success rate than the other brands. Also, we will see the different brands have a different implant tomography. Means that some implant may have more groove or even have some porosity over the surface. Each different design actually be claimed that they have a better performance or the even performance than the others. So the most important when you select the implant brand for your practice is to understand if they have enough clinical study or clinical experience can be supported their design. And also you may want to ask your experienced colleague about their experience to using those specific brand to give you a hint about the success rate in the long-term treatments. Implant stabilities also will be important factors to affect the implant osseointegrations. When we talk about the implant stabilities, it could be divided by primary stabilities and the secondary stabilities. The primary stabilities is majorly from the mechanisms of the old bone. The secondary stabilities is from the biological factors from the new bone. So far, you may confuse with those two different terminologies. So let me explain that. When we look on the primary stabilities, think about today you go to IKEA to buy some items and try to put a nail over the wall. So you create a hole and try to screw the nail into the wall. When you continue screwing the nail into the wall, then you will feel the nail will be more and more tightened. So that will be the same as what we call the primary stabilities of the implants. So when we create a socket and then we place an implant into the bone, we screw the implant into the hole. So the old bone will be more and more close to the implant surface and finally give enough primary stabilities. However, our bodies also will develop the new cell. So when we have a new bone cell deposit to the implant surface, they will also increase the bone to implant ratios. So that would be the secondary stabilities from. If you look on these pictures, actually it shows you about how the primary stabilities and the secondary stabilities to affect the osseointegrations. So the red line means from primary stabilities. So as you can see, the primary stability is in the maximum in the first beginning. However, followed by the bone remodeling, that will decrease. The green line shows you the secondary stabilities because once the bone remodeling, even though the old bone cell will resorpted, but the new bone will be formed. As the new bone be formed, the secondary stability will increase as the green line shows. So finally, we can sum up both effects into total stability as the blue line shows. As you can see, the total stability actually is higher in the first beginning, but will start to decrease because the primary stability is decreasing more sooner than the secondary stabilities. So the worst total stabilities usually to happen around the week 6 is about 1.5 months after the surgery. After that, the line will come up again and reach to a higher total stability. Means that implant is fully operated by the osseointegrations. And this also comes up to a concept to say that it is not be suggested too early to put the restoration of the implants around the 1 to 2 months because it may cause a poor stability implant to fail. Another important factor to affect the osseointegration is the bone qualities. In 1985, 2 researchers studied from the bone sample from the patients and find out 4 different kinds of bone. So they developed a wild used classifications from quality 1 to quality 4. As you can see, the quality 1 means that the bone has a homogeneous compacted bone, means that it has a hard bone. However, the quality 4 means the bone just have very thin layer of cortical bone, and inner side will be with the low density trabecular bone. So total, the quality 4 bones means that that's a poor strength and poor quality of the bone. If we look on the maxilla and the mandible used to have quality 1 to quality 2 bone, and the maxilla used to have quality 3 and quality 4 bones. As we mentioned earlier, that the bone quality will affect the osseointegration. So in general speaking, if you place an implant into the maxilla, you will expect that the implant osseointegrations will take a longer time compared to the implants in the mandible. The last factor to affect the osseointegration of implants will be the bone quantities. So this is a classification to talk about how the bone defect. The class 1 defect means that it will just happens around buccolingual. The class 2 means that the defect is happen only on apical coronal. The class 3 means it was a combination of the buccolingual and apical coronal. So if we have more and more bone defect, means that we will need more and more new bone material to accumulate to get the implant. It also means the healing time or the osseointegration time will be delayed if patient lost more bone. In the following slides, that I would describe the difference between the peri-implants versus the periodontal tissues. Now you can see this is a cross-section of the pictures of the tooth and the implant and their surrounding tissues. On the left side, the tooth part shows you that the root is not directly fixed with the bone. There's some tissue between the tooth root to the bone, which is what we call the PDL, the periodontal ligament. Also, you can find out that over the cervical, under the junction epithelium, they'll have more connected tissues adhere from the gingiva to the tooth. On the right side is the cross-section pictures of the implants. So the first difference is the implant is directly fixed with the bone, and there are few connective tissues around the gingiva to the implants. So how those two major differences between the peri-implant and the periodontal tissues really affect our clinical applications? So as we know, the natural tooth has more firmly dental gingival collagen fibers, so it can be served as a barrier to prevent the epithelial migrations and the bacterial invasions. However, the connective tissue adhesion with the implant has a poor mechanism to resist it compared to the natural tooth. So it comes out that if the implant has a peri-implantitis, actually the prognosis used to be worse than the natural tooth. The second is when the implant doesn't have a periodontal ligament, it causes that the force to the implant couldn't be resorpted by the PDL ligament or will always directly put to the bone. So eventually that will cause that the implant itself is not able to resist it by the lateral movement. So when we do a occlusal adjustment for the implant restorations, that we have to put the implant restoration have lighter occlusal contact compared to the restorations onto the natural tooth. In the last few slides, I would like to introduce you a concept of the socket preservations. So when we took the tooth out and made nothing until it was fully healed, the research really shows us that we'll have 40 to 60% bone volume lost during the healing process. So it means that if we want to place an implant into the missing tooth area, that we might not have enough bone volume to place the implant. So if we can find out a way to preserve the bone during the healing process, that will be important of the success rate of the implant placement. That's why it comes out a concept was called socket preservation. So the socket preservation means that the surgeon extracts the tooth and then at the same time they will put the bone graft and the membrane over the socket. So once the wound healings, that those bone graft and the membrane can keep the socket volumes and to prevent the severe resorptions. So eventually we will have more bone volume be kept for the implant placement. The recent research also shows the evidence that when we do a systemic review, that evidence shows the socket preservation procedure actually can attenuate the dimension reductions. So it means we will not be able to increase the bone. However, we can decrease the resorption of the bone volume. And also, it was highly suggested that the socket preservation should be considered in conjunction with minimum trauma tooth extraction. So, if you have a patient with a poor prognosis tooth or a non-restorable tooth and has an interested into implant restoration, then you should not just only plan the tooth extraction, you also need to plan to do a socket preservation at the same time with the tooth extraction so you can preserve the most bone volume for the following surgical procedure.